Alright, so after having discussed about the neurology quick revision, now let us just take up the nephrology quick revision. So the PPT of this nephrology quick revision has already been posted in Dr. Banu Prakash Telegram channel and as well as my Telegram channel, that is Medicine Made by Dr. Rajesh Gupta. So immediately after the session, I'll also post the PPT with annotations as well. So now in the nephrology quick revision, what all the topics that we'll be discussing is the acute kidney injury, chronic kidney injury, nephrotic nephritic syndrome, polycystic kidney disease, renal tubular acidosis, and as well as the hereditary nephropathies, that is Bartels, and as well as the Gentleman's and Alport syndrome as well. Now let us take up the discussion of the acute kidney injury first. So if you take the acute kidney injury, like what should happen here? There should be abrupt increase in serum creatinine. So how much should be increase in serum creatinine levels in acute kidney injury? It should be more than or equal to 0.3 milligrams per deciliter. That should be elevated within 48 hours. That should be increased within 48 hours, or there should be a decrease in the urine volume. And how much should be the decrease in urine volume? Decrease in urine volume should be less than 0.5 ml per kg per hour, and this particular decrease in urine volume less than 0.5 ml per kg per hour, that should be there for nearly around 6 hours. Okay, so this is the definition of acute kidney injury according to your KDIGO guidelines. And what is the normal urine output? So if you take the normal urine output is 1 ml per kg per hour. That is a normal urine output. But whereas in acute kidney injury, it is less than 0.5 ml per kg per hour for nearly around 6 hours. Now, what exactly is the definition of the anuria? See, anuria is defined as the urine output less than, right? This is one of the PYQ. So please remember the answer is less than 4 ml per hour. Now, see, according to the KDIGO guidelines, this is the definition of acute kidney injury. But we have one more important criteria, that is called acute kidney injury network criteria. In the acute kidney injury network criteria, what they have mentioned is the staging of acute kidney injury, that is stage 1, 2, 3. In stage 1, the creatinine is elevated 1.5 to 2 folds and the urine output is reduced less than 0.5 ml for more than 6 hours. Whereas in stage 2, the increase in serum creatinine is like 2 to 3 folds and urine output is being reduced less than 0.5 ml per kg per hour for more than 12 hours. Whereas in the stage 3, the serum creatinine is elevated more than 3 folds and the urine output is reduced less than 0.3 ml per kg per hour for 24 hours. So this is what is the staging of the acute kidney injury. Now you need to know the three important etiologies of acute kidney injury, that is pre-renal, intrinsic renal, and as well as the post-renal. So what is pre-renal? Pre-renal means the perfusion to the kidney should be reduced. So the perfusion to the kidney will be reduced because of intravascular volume depletion. So the intravascular volume depletion can occur in hemorrhage, gastrointestinal loss, and as well as the renal loss. And the decreased renal perfusion can occur because of decrease in cardiac output. That is because of the congestive heart failure, aortic stenosis, or mitral regurgitation or aortic regurgitation. Then the decreased renal perfusion can also occur in renal vasoconstriction, which is being caused by the hypercalcemia, sepsis, or liver disease. And these are all the etiologies which will cause pre-renal. Pre-renal means where the perfusion to the kidney will be reduced. Then intrinsic renal. So intrinsic renal means the pathology will be within the kidney, right? So what will be that pathology within the kidney? Like we have some large vessel diseases, glomerular diseases, acute tubular necrosis, and interstitial diseases which will be causing intrinsic renal type of acute kidney injury. So out of this, acute tubular necrosis is very, very important. This acute tubular necrosis to occur, like we have the exogenous toxins and as well as the endogenous toxins. What are the exogenous toxins? Exogenous toxins are mainly the antibiotics, anti-cancer agents, and radio contrast material. And what are the endogenous agents? The endogenous agents are mainly myoglobinuria, hemoglobinuria, light chain, that is in case of multiple myeloma, and uric acid, that is in case of gout or gouty arthropathy, tumor lysis syndrome. That will be the endogenous cause for your acute tubular necrosis. Okay. Now, very important is you should be able to differentiate pre-renal from intrinsic renal, right? Pre-renal from intrinsic renal. Now, you see this question. Investigation in a patient of oliguria revealed urine osmolality 800 milliosmoles, urine sodium 10 millimoles, Bun to creatinine ratio 20:1. The most likely diagnosis is pre-renal, acute tubular necrosis, acute cortical necrosis, urinary tract obstruction. So now how will you differentiate pre-renal from the intrinsic renal? So 2-3 parameters are there which are very, very important. What are those 2-3 parameters here? 1 to creatinine ratio. So if you take blood urea nitrogen to the creatinine ratio, if it is more than 20, that will be pre-renal. But if 1 to creatinine ratio, if it is like less than or equal to 20, if they are like less than or equal, I'm sorry, if 1 to creatinine ratio, if it is less than 10 to 15, that will be the intrinsic renal. Right? How much is here? 20 is to 1. So this becomes your pre-renal type of the acute kidney injury. And one more important is the fraction excretion of sodium. So in pre-renal, the fraction excretion of sodium will be less than 1, whereas here it will be more than 1. So these are the two important parameters which will differentiate pre-renal from intrinsic renal type of acute kidney injury. Then followed by that, you need to know what are the post-renal causes for acute kidney injury. In males, the most common cause for post-renal type of acute kidney injury will be benign prostatic hyperplasia. That is the most common cause in males. And apart from that, the other etiologies that will be causing post-renal will be the renal calculi, ureteric calculi, the bladder stones, right? So these are all the post-renal cause for your the acute kidney injury. And next is the fibrosis, right? This particular fibrosis can occur in patients like scleroderma, or in the patient who is on drugs like bleomycin or methotrexate, right? Bleomycin or methotrexate. Even these can cause the fibrosis. So bilateral ureteric fibrosis, right? Bilateral ureteric fibrosis. This can cause post-renal type of acute kidney injury. Right, this can cause post-renal type of acute kidney injury. So what are the causes for bilateral ureteric fibrosis? Scleroderma and drugs like bleomycin and methotrexate. Okay, right. Now what are the manifestations of your acute kidney injury? So we have initiation, maintenance and diuretic phase. So in the initiation phase, there is just decrease in the renal blood flow. There is just decrease in the renal blood flow, and this will be there for up to 36 hours of onset of acute kidney injury. Whereas your maintenance or oliguric phase, here the GFR is reduced maximally. Right, here the GFR is reduced maximally in case of maintenance or oliguric phase, and this maintenance or oliguric phase will be there for nearly around 1 to 2 weeks. Will be there for nearly around 1 to 2 weeks. And in maintenance phase, you will have all the uremic complications and you will have all the electrolyte abnormalities. What are all the electrolyte abnormalities that you can have in maintenance phase? Hyperkalemia, hyperphosphatemia, hypermagnesemia, hyperuricemia, right? And there will be elevation of blood urea nitrogen. So why do you think this electrolyte abnormality like hyperkalemia, hyperphosphatemia, hypermagnesemia, hyperuricemia and elevated blood urea nitrogen will be there? That is because of reduced excretion, right? And they will have hyponatremia. Why is that? That is because of dilution. Dilutional hyponatremia will be there because of volume overload. Then there will be also hypocalcemia. Why? Because phosphate level is elevated. That increased phosphate will combine with calcium, resulting in the hypocalcemia. Then in recovery or diuretic phase, all the electrolyte abnormalities will be reversed, right? So this will be there after 2 weeks once you treat the patient, right? All the electrolyte abnormalities will be reversed. Hyponatremia will become hypernatremia, hyperkalemia will become hypokalemia, hyperphosphatemia will become hypophosphatemia, hypermagnesemia will become hypomagnesemia, hyperuricemia will become hypouricemia, but only thing which will be there is your hypocalcemia. That will persist. Why is that? Because calcium has been precipitated in the form of calcium phosphate. So that will be there even in your recovery or diuretic phase. So overall, if you take the clinical manifestations, the clinical manifestations are due to decrease in urine output, right? Decrease in urine output. There will be oliguria. So when do you call it as oliguria? You call it as oliguria when the urine output is less than 400 ml per 24 hours. Then you will have all the features of uremia. What are all the features of uremia? See, the urea level is elevated here, and this particular urea goes and gets accumulated in various parts of the body. So there can be uremic encephalopathy, right? There can be uremic pericarditis. There can be uremic gastroparesis. Okay, so these will be the features of the uremia, and you will also have the features of the fluid overload. So what will be the features of the fluid overload? That is the pleural effusion. There can be also development of the pericardial effusion, right? And there can be also development of ascites, and there can be also development of edema. So these are the features of the fluid overload. And in certain etiologies causing acute kidney injury, the color of the urine also changes. See, in case of the hemoglobinuria, you will have the red color urine. And in case of myoglobinuria, that is in case of rhabdomyolysis, you will have the brown colored urine. So these will be the clinical features of the acute kidney injury. Then how do you work up these patients? So first and foremost, definitely the serum creatinine. The serum creatinine level will be elevated, and even urea levels are also elevated. But when you do a complete blood picture, there will be anemia, right? There can be anemia, and eosinophilia will be there. But in which condition of acute kidney injury you will have the eosinophilia? Eosinophilia and eosinophiluria, it indicates atheroembolic kidney disease, right? Eosinophilia and as well as eosinophiluria, you will have atheroembolic kidney disease, right? And when you do a urine examination, there can be presence of even the cast. And electrolytes already I have discussed. Potassium is elevated, dilutional hyponatremia will be there, serum calcium level reduces, serum phosphate levels increases, and fraction excretion of sodium in pre-renal it will be less than 1, and in intrinsic renal it will be more than 1, right? And very important is the ECG. ECG will show you that there will be presence of tall T waves. Why is that you have tall T waves? That is because of the hyperkalemia. And next is the imaging, that is ultrasonography. This ultrasonography is more important in case of post-renal type of acute kidney injury, to look for benign prostatic hyperplasia, to look for ureteric calculi, to look for renal calculi, to look for bilateral ureteric fibrosis. That will be the importance of your USG. And next is the ABG, arterial blood gas analysis. The arterial blood gas analysis will show you that there is metabolic acidosis. Why is that? Because of loss of bicarbonate. Thereby there will be metabolic acidosis. So these are the investigations that you will have in acute kidney injury. Now, how do you treat these patients? So treatment in case of acute kidney injury, it completely depends upon what is the underlying cause of acute kidney injury. Like for example, rhabdomyolysis, you need to do forced alkaline diuresis, right? If it is like, if there is like volume overload, you need to do salt and water restriction, and you need to give diuretics, that is you need to give furosemide, right? And for hypertension, we give labetalol. Because of the fluid overload, there can be hypertension causing fluid overload can cause hypertension, for which you need to give labetalol. And these patients can also have the dilutional hyponatremia causing the altered sensorium. So one is the fluid restriction, but if the individual develops symptomatic hyponatremia, then like symptomatic hyponatremia means what? Because of hyponatremia, there can be development of seizures. In these patients, you need to give 3% sodium chloride. And if the individual develops hyperkalemia, the drug of choice for hyperkalemia will be calcium gluconate. And next to the calcium gluconate, you need to give the other drugs. What are the other drugs? Like diuretics. Then your beta 2 agonists like salbutamol nebulization, right? And potassium binding agent, that is sodium polystyrene sulfonate, right? So these are the drugs that we give for hyperkalemia. And if there's metabolic acidosis where the pH of the individual is less than 7 and bicarbonate level is if it is less than 10, then you should give sodium bicarbonate, right? You should give sodium bicarbonate. Then hypocalcemia or hyperphosphatemia. See, whenever there is hypocalcemia, the individual will have the features of hypocalcemia. What is that? Perioral paresthesia and as well as periungual paresthesia, and there can be also tetany. So for them, you need to give calcium gluconate. Then how do you treat this? The hyperphosphatemia. The hyperphosphatemia, you need to give phosphate binding agents. What are those phosphate binding agents? That will be your calcium acetate, then sevelamer hydrochloride, then aluminium hydroxide. So these are the drugs that we give for hyperphosphatemia. That is phosphate binding agents like calcium acetate, sevelamer hydrochloride, and then aluminium hydroxide. Okay. Then next is the hyperuricemia. So hyperuricemia, you can have that in case of the tumor lysis syndrome. So whenever there is hyperuricemia, that is in tumor lysis syndrome, you need to give a uricosuric agent, and that particular uricosuric agent is rasburicase, right? Or you need to give a drug which will decrease the uric acid synthesis, and that will be allopurinol. That will be your allopurinol. So this is a treatment for your acute kidney injury. Next is hypertensive crisis. Already just now we have discussed. That is, we need to give labetalol, right? We need to give labetalol. Then followed by that, what is the indication for dialysis? The indication for dialysis, please remember this mnemonic, that is have P. H stands for refractory hyperkalemia. That means patient is not responding to your insulin supplementation, patient not responding to your beta 2 agonist salbutamol supplementation, patient not responding to your potassium binding agents. Refractory hyperkalemia, you need to do dialysis. And refractory acidosis, right? In spite of giving sodium bicarbonate, still acidosis is persisting, then do dialysis, right? And refractory volume overload, that means you have done salt and water restriction, you have given furosemide, but still there is volume overload, do dialysis and take out the fluid. Elevated blood urea nitrogen, right? Blood urea nitrogen levels more than 35 millimoles, then you need to do dialysis. P stands for pericarditis, that is uremic pericarditis. E stands for uremic encephalopathy. E stands for the pulmonary edema, right? Pulmonary edema. So these are all the indications for dialysis, and this completes the discussion of your acute kidney injury, right? Now, once we are done with acute kidney injury, the next important topic is the chronic renal failure. So the definition of the chronic renal failure is based on the GFR. When the GFR, if it is less than 60 ml per minute per 1.73 meter square, along with that there is proteinuria, right? Along with that there is proteinuria which is being present for more than 3 months, then we consider it as the chronic renal failure. How much is a normal GFR? That is around 90 to 120 ml per minute. That is a normal GFR. But when the GFR reduces to less than 60, along with that proteinuria is there for more than 3 months, then we call it as the chronic renal failure, right? Now, next important is we stage the chronic renal failure into stage 1, 2, 3, 4, 5 based on the GFR value. So in stage 1, the GFR is more than or equal to 90, but there will be kidney damage. That means GFR is normal, but there is kidney damage, right? Whereas you take stage 2, kidney damage with mild decrease in the GFR. How much will be that? 60 to 89. Whereas in 3A, the GFR will be 45 to 59. Whereas in stage 3B, the GFR will be 30 to 44. Whereas in stage 4, the GFR is 15 to 29. When do you call end stage renal failure? When GFR is less than 15, then we call it as the end stage renal failure. Okay, so this is about the stages of the chronic renal failure. And this stage 5, we classify that into stage 5D and as well as stage 5T. 5D means the individual undergoing dialysis. 5T means the patient who has undergone the transplant. And what is the most common cause of chronic renal failure? Most common cause of chronic renal failure will be your diabetes mellitus. Now, what are the manifestations? The manifestations in patients with the chronic renal failure will be, number 1, there will be renal osteodystrophy. What is renal osteodystrophy? See, these patients with chronic renal failure, they will have severe hypocalcemia because vitamin D will not be there. So whenever there is severe hypocalcemia, there will be increase in parathormone secretion causing bone resorption, causing renal osteodystrophy, right? The other important points are anemia, because erythropoietin is not there. So there will be normocytic, normochromic type of anemia. And there will be leukopenia, because of which there will be increased infection. And there will be also thrombocytopenia, because of that there will be bleeding manifestations in these patients with the chronic renal failure. There will be growth retardation. Why is that? That is because of your anemia and renal osteodystrophy, there will be growth retardation. And you will have all the features of uremia, that is uremic encephalopathy, uremic pericarditis, uremic gastroparesis, everything will be there. And because of the fluid overload, the same features whatever we have discussed in acute kidney injury, pleural effusion, pericardial effusion, ascites and edema and hypertension will be there. And because of the accumulation of urea in the peripheral nervous system, there will be peripheral neuropathy. Gastrointestinal manifestations can be there, that is in the form of hiccups. They can also have the vomiting. So these are the GIT manifestations. And if you take the dyslipidemias, so there is decrease in lipoprotein lipase activity, right? There is decrease in lipoprotein lipase activity in chronic renal failure, and that is the one which will cause the dyslipidemia. And genitourinary manifestations, if you see, these patients, they will have impotency and isostenuria. Isostenuria means the specific gravity of the urine will be similar to that of specific gravity of the plasma. That will be the genitourinary manifestations. And what are the skin manifestations? These patients, they will have xerosis, where there is drying of the skin, right? And they will have the bleeding manifestations. There will be like ecchymosis, and there will be also edema. And why is this xerosis? That is because of accumulation of urea within the skin. Now, if you take this particular nails, they'll have this characteristic half and half nail. And this particular nail, it is also called as the Lindsay nail. Why is that? That is because of increase in the capillary density in the proximal half of the nail. And this is what is called Lindsay nail, or this is also called as the half and half nail. Then what will happen to the kidney size in patients with the chronic renal failure? The kidney size will be reduced in patients with the chronic renal failure. That's a very, very important point. Then how do you treat these patients with the chronic renal failure is very, very important now. So what is the most common cause for chronic renal failure? That is diabetes mellitus. So you have to see that the HbA1c of the individual is less than 7%, for which the treatment is insulin. Blood pressure should be under control, less than 130/90, for which we give labetalol or we give calcium channel blocker. Right? Cholesterol, the LDL should be less than 70. LDL should be less than 70. And for maintaining the LDL less than 70, you need to give statins. Right? And next thing is, these patients, they have vitamin D deficiency, right? Because the kidney is damaged. So you need to give vitamin D supplementation. Along with the vitamin D supplementation, you need to give cinacalcet. Right? Cinacalcet. And this particular cinacalcet, it prevents the release of parathormone. Right? Cinacalcet prevents the release of parathormone. That is about your cinacalcet. Then next is erythropoietin, that is mainly to treat the anemia, and this is given subcutaneously. This is given subcutaneously. And what are the forms of erythropoietin? We have epoetin alpha and darbepoetin alpha. Right? Epoetin alpha and darbepoetin alpha. So these are the erythropoietin supplements. That is mainly to treat the anemia, that is normocytic normochromic type of anemia. So this is what is the treatment of the chronic renal failure. Right? Now, what is that we have discussed is about the renal replacement therapy. So when the GFR is less than 15, that means when the individual is in CKD stage 5, renal replacement therapy is done either by dialysis, right? Either by dialysis or renal transplantation. For doing dialysis, you need to create a fistula. That means those individuals who require long-term dialysis, every week, 2 times, 3 times dialysis is required. In them, you need to create an arteriovenous fistula. And this particular fistula is created between the radial artery and as well as the cephalic vein. And what is the name of the fistula? The name of the fistula is the Seminobrecia fistula. And this Seminobrecia fistula, the name is given in the honor of an Italian doctor because he is the one who has made this first. And the advantage of making the fistula is that there is reduced chances of development of thrombophlebitis. Right? Thrombophlebitis chances can be decreased by your creating the fistula. And what is the principle of your hemodialysis? That is countercurrent mechanism. And most common complication of dialysis is hypotension, because you are taking out lots and lots of quantity of the fluid out of the body and you are sending it to your dialyzing machine. So hypotension is the most common complication. And most common complication of recurrent hemodialysis will be accelerated atherosclerosis. Right? Accelerated atherosclerosis. And these patients who are undergoing dialysis, they also develop dialysis dementia. And this dialysis dementia, why is this dialysis dementia due to? This particular dialysis dementia is due to accumulation of the amyloid protein. Right? And this amyloid beta 2 also gets accumulated in the flexor retinaculum, resulting in the carpal tunnel syndrome. And those individuals who are undergoing dialysis, there will be also B7 deficiency, resulting in burning foot syndrome. Right? Resulting in burning foot syndrome. So these are the other complications, but most common complication is what? The hypotension. And most common complication of recurrent hemodialysis is what? That is accelerated atherosclerosis. And this particular dialysis can be done in 2 ways. One is your peritoneal dialysis and the other one is hemodialysis. Peritoneal dialysis, it can be done even in the home. It is slow process, but hemodialysis is usually done in the hospital and it is slightly the fast process. That is what is your peritoneal and as well as the hemodialysis. And in case of your peritoneal dialysis, remember what is that membrane which is being used? That is peritoneum itself will be used as a membrane for removing the impurities. Actually, the peritoneum is filled with the dextrose solution, and into this particular dextrose solution across the peritoneal membrane, the impurities will add, and this dextrose solution is being removed. Okay, so that is what is the peritoneal dialysis, right? Now, after having discussed about one form of renal, see, there are two forms of renal replacement therapy. One is your dialysis and the other one is kidney transplantation. So if you take this kidney transplantation, which particular kidney is preferred? That is allogenic kidney is being preferred. That is from the first degree relative. And whenever you are doing kidney transplantation, HLA matching and blood grouping should be done mandatorily. The HLA matching is being done for which the gene is located on chromosome 6, and blood grouping is being done for which the gene is being located on the chromosome 9. And whenever you are taking the kidney from the donor has to be tested for HIV, the donor has to be tested for HBV, the donor has to be tested for the HCV, right? So, and even the cytomegalovirus. And in the recipient, what is that you have to do? You need to do the Doppler. Doppler has to be done in the recipient, that is mainly to rule out the renal artery stenosis. And which particular kidney of the donor is taken? That is left kidney of the donor has to be removed. Why? Because the left renal vein is longer. Right? The left renal vein is longer. So left kidney of the donor has to be removed. And within the recipient, where do you keep this new kidney? This new kidney is placed in the right iliac fossa. Right? It is placed in the right iliac fossa. Okay? Right. And see, while doing kidney transplantation, definitely you have to do your HLA matching and blood grouping. But for liver transplantation, HLA matching is not required. Now, whenever you keep the kidney in the recipient, immediately what is the problem is the rejection. Because your kidney is being taken from a donor. It's a foreign body for the individual recipient. So rejection is very, very common. So hyperacute rejection, it's a type 2 hypersensitivity reaction. And this will occur within few minutes of anastomosis. Then next thing is acute rejection. Acute rejection is that which occurs within 6 months of surgery. And because it is occurring within 6 months of surgery, it is a type 4 hypersensitivity reaction. And next thing is chronic rejection. Chronic rejection is that which occurs after 6 months of surgery, and this is also a type 4 hypersensitivity reaction. And to prevent the rejection, you need to give the immunosuppressive agents. That immunosuppressive agents are, that is cyclosporin, then azathioprine, then prednisolone. These are the drugs that you need to give to prevent the rejection. Cyclosporin, azathioprine, and then the prednisolone. But whenever you are giving these immunosuppressants, the individual is at increased risk of the opportunistic infections, right? Now, what are the opportunistic infections that can occur within 1 month of giving the immunosuppressive drugs? Within 1 month, the individual is increased risk of the herpes simplex infection, or the individual can also have the MRSA infection. Within 1 to 6 months, the opportunistic infection that can be there is the pneumocystis jirovecii pneumonia and viral infections like cytomegalovirus, then HBV virus and HCV virus. And after 6 months of the chemotherapy or immunosuppressant therapy, the opportunistic infection here is the aspergillus, which is nothing but the fungal infection. Okay, so this is about your renal replacement therapy, right? Hemodialysis is one, then renal transplantation is the other one, right? So we are done with the chronic renal failure. The next topic is the renal tubular acidosis. So if you take this renal tubular acidosis, what are the types? We have type 1, type 2 and type 4 renal tubular acidosis. You don't have type 3, type 1, type 2 and as well as type 4, right? So let me discuss about type 1 renal tubular acidosis. See, type 1 renal tubular acidosis, this is also called as distal renal tubular acidosis. Where exactly will be the problem? The problem will be at the level of the collecting duct. And in these patients with type 1 renal tubular acidosis, let me tell you, it is not called Fanconi's syndrome. Fanconi's syndrome is what? It is type 2 renal tubular acidosis. And in these patients, they are at increased risk of calcium stone formation. And your renal tubular acidosis, it is hyperchloremic, right? It is the hyperchloremic normal anion gap metabolic acidosis, right? Hyperchloremic normal anion gap metabolic acidosis. So there is no anion gap. And in these individuals, they will also have the hypokalemia. So your type 1 renal tubular acidosis is what? Distal renal tubular acidosis. And what are the etiologies that can cause your type 1? That is some of the drugs. We have an antifungal drug called amphotericin B. This amphotericin B can cause your type 1 renal tubular acidosis. And not only that, the paraproteinemias, right? Paraproteinemias are nothing but your monoclonal gammopathies. Even they can cause your type 1 renal tubular acidosis. And what are the features of your type 1 renal tubular acidosis? Just now we have discussed that they will have the hypokalemia, right? And these patients, they will have metabolic acidosis, and there will be renal stone formation, that is the calcium stone formation will be there. And these patients, they will have the alkaline urine. They'll have alkaline urine. Then how do you treat these patients with type 1 renal tubular acidosis? See, they're having acidosis, so you need to give IV sodium bicarbonate, right? IV sodium bicarbonate. And this IV sodium bicarbonate that you are giving is, that is 2 to 3 milliequivalents per kg. That is what you have to give in type 1 renal tubular acidosis. Then you take type 2 renal tubular acidosis. Type 2 renal tubular acidosis, that is also called proximal, whereas your type 1, it is distal renal tubular acidosis. So if you take type 2 renal tubular acidosis, which is also called proximal renal tubular acidosis, what is the etiology that will be causing your type 2? In type 2, the etiology is mainly the drugs. What are those drugs? That is carbonic anhydrase inhibitors, that is acetazolamide is the one which can cause your type 2 renal tubular acidosis. And the other condition is the plasma cell myeloma. Even this can cause your type 2 renal tubular acidosis. What exactly is the problem in type 2 renal tubular acidosis? At the point of PCT, there should be reabsorption of bicarbonate. And in type 2 renal tubular acidosis, the reabsorption of bicarbonate at the level of proximal convoluted tubule does not occur. That is what is your type 2 renal tubular acidosis, right? That is what is called type 2 renal tubular acidosis. And this type 2 renal tubular acidosis, this is also called as the Fanconi syndrome. This is also called as the Fanconi syndrome. And in these patients, there is no renal stone formation. There is no renal stone formation. And even in these patients also, they will have hypokalemia. But you don't have an alkaline urine, right? In these patients, they will have the urine of pH more than 5.5. The alkaline urine is classically seen in case of your, the urinary pH here, it will be less than 5.5. Whereas the alkaline urine is classically seen in case of type 1 renal tubular acidosis. Okay. Whereas in type 2 renal tubular acidosis, the urinary pH will be less than 5.5 and there is no renal stone formation in these patients. Now, how do you treat these patients with proximal renal tubular acidosis? You need to give IV sodium bicarbonate. This IV sodium bicarbonate, the dosage is 10 to 15 milliequivalents per kg. Right, 10 to 15 milliequivalents per kg. That is what you have to give in case of your type 2 renal tubular acidosis. Whereas in type 1, 1 to 2 or 2 to 3 milliequivalents per kg of your sodium bicarbonate should be given. But here it is 10 to 15. Why? Because the problem itself is your bicarbonate loss. So that is the reason why you should give high dose of bicarbonate. Now, if you see the differences between proximal and as well as distal, proximal is what? It is your type 2. Distal is what? Type 1. Pathogenesis in type 2 is what? Failure of bicarbonate reabsorption in your type 2. Whereas problem in distal is what? There is defect in the secretion of the H plus. Right? There is defect in the secretion of the H plus at the level of the distal tubule. And growth failure is present in both of these conditions. And rickets and osteomalacia is also present in both of these conditions. Nephrocalcinosis is present in the type 1, absent in case of proximal renal tubular acidosis. And what are the other tubular effects? That is very common in case of the Fanconi. Your type 2 is your Fanconi, where you can have other tubular effects. Then coming to your type 4 renal tubular acidosis. See, type 4 renal tubular acidosis, this is due to aldosterone deficiency or the aldosterone resistance. See, what exactly is the function of aldosterone? Sodium and water retention, H plus ion secretion and K plus ion secretion. The H plus and K plus should be out by your aldosterone. But here what is happening? Aldosterone is not there or there is aldosterone resistance. So the H plus will increase. That will result in acidosis. And in these patients, they will also have hyperkalemia. See, the differential point is in your type 1 and type 2, you have hypokalemia. But this is the only condition where this is the only form of renal tubular acidosis where you will have the hyperkalemia. Then what are the drugs that will be causing your type 4 renal tubular acidosis? That is the drugs which will reduce your aldosterone levels. What are the drugs which will decrease the aldosterone synthesis? That will be ACE inhibitors. That will be the angiotensin receptor blockers, right? And your diuretics. Which particular diuretics? Aldosterone receptor antagonists, that is spironolactone and as well as the eplerenone. And one more drug is trimethoprim and as well as the pentamidine. So these are the drugs which can cause type 4 renal tubular acidosis. And apart from these drugs, you have some systemic conditions also. What are the systemic conditions? Diabetic nephropathy, interstitial nephritis, HIV, Addison's, sickle cell disease. All these can cause your type 4 renal tubular acidosis. And what is the treatment for type 4 renal tubular acidosis? Already there is high potassium. So dietary potassium restriction, right? The diet which is rich in potassium, like fruits, no fruits. Coconut water, no coconut water, because they are the one which are rich in potassium. And you need to give loop diuretics. This particular loop diuretics can cause the excretion of your potassium. Now what do we want? We want an aldosterone. So what is an aldosterone analog? The aldosterone analog is the fludrocortisone. So fludrocortisone is the drug of choice in case of type 4 renal tubular acidosis. So this completes the discussion of all the types of renal tubular acidosis, type 1, type 2 and type 4. Okay. So what type of acidosis is your renal tubular acidosis? Hyperchloremic normal anion gap metabolic acidosis, right? And there are some important points of differences from type 1, type 2, type 3. Type 1 and type 2 you will have hypokalemia. Type 4 will have hyperkalemia. Renal stone formation is there only in type 1. Type 2, type 4 you don't have the renal stone formation. Fanconi syndrome. Only your type 2 is called Fanconi. The remaining type 1 and type 4, it is not Fanconi, right? So these are some of the differences that you need to know among all these forms of renal tubular acidosis, right? Now, after having discussed about the renal tubular acidosis, now let me take up the discussion of renal vascular disorders. You see this question. A 10-year-old child develops hematuria after 2 days of the diarrhea. The blood film shows the fragmented RBC and thrombocytopenia. Ultrasound shows marked enlargement of both the kidneys. So what do you think is the likely diagnosis in this patient? Acute pyelonephritis, disseminated intravascular coagulopathy, hemolytic uremic syndrome, renal vein thrombosis. So what does this clinical picture appears like? Actually, you may think the clinical picture is suggestive of the hemolytic uremic syndrome, right? But the answer is not hemolytic uremic syndrome. The answer is renal vein thrombosis. Now, why the answer being renal vein thrombosis? Remember, in hemolytic uremic syndrome, you will have normal sized kidneys. Now, the presence of enlarged kidneys, that makes the answer as renal vein thrombosis. Okay, so marked enlargement of both the kidneys, it is suggestive of renal vein thrombosis. But the only problem is, whenever there is bilateral renal vein thrombosis, there will be bilateral enlargement of the kidneys. That particular time, it is difficult to distinguish the hemolytic uremic syndrome. It is difficult to distinguish hemolytic uremic syndrome. And this particular renal vein thrombosis, it is preceded by the gastroenteritis in both children and as well as adults, right? What is the most common cause of your renal vein thrombosis in children? That is the gastroenteritis. See, gastroenteritis will cause very severe dehydration, and this particular dehydration will precipitate for the development of the renal vein thrombosis. Whereas you take in adults, the most common cause of renal vein thrombosis will be membranous glomerulonephritis, right? Membranous glomerulonephritis. Okay, then now how will you diagnose renal vein thrombosis? That is by Doppler flow study. So when you do a Doppler flow study, right, or angiography of inferior vena cava, that will confirm the diagnosis of renal vein thrombosis, right? And what is the treatment? Because it's a renal vein thrombosis, you need to give the anticoagulant. So the very important point is, in these patients, there will be marked enlargement of both the kidneys. And in these patients, you take in children, the important etiology is the preceding gastroenteritis. So if you see this particular question, our patient is having the preceding diarrhea. And in these patients, you can have the fragmented RBC and there can be also thrombocytopenia. So these are the features of the renal vein thrombosis. Now, one more important renal vascular disease. So just now what we have discussed is renal vein thrombosis. Next is the renal artery stenosis, right? So what do you think is the most common cause of renal artery stenosis in young adults in India? The options are atherosclerosis, non-specific aortoarteritis. Then the other options are fibromuscular dysplasia, none of the other. So you take in young adults in India, that will be non-specific aortoarteritis. Atherosclerosis is the most common cause of renal artery stenosis in adults, that is old patients, whereas fibromuscular dysplasia is the most common cause of renal artery stenosis in young patients in Western countries. Right? In Western countries, the fibromuscular dysplasia is more common in young adults. Whereas in India, it will be non-specific aortoarteritis, right? Which is nothing but your Takayasu. Now, what do you think is the clinical features that you will have in patients with a renal artery stenosis? See, in renal artery stenosis, these patients, they will present with very severe hypertension. Why? Because of activation of RAS. And bilateral renal artery stenosis, it is present in almost 50% of cases. And these patients, they can have episodic or they will have recurrent flash pulmonary edema. Right? They will have recurrent flash pulmonary edema. And whenever there is recurrent flash pulmonary edema, they are the candidates who have to undergo renal artery stenting. They have to undergo renal artery stenting. And when you do examination, right, when you do examination of the abdomen, you will listen a bruit, right? You will listen a bruit over the abdomen. So these are the clinical features of the renal artery stenosis. Now, what is the screening procedure of choice? The screening procedure of choice is gadolinium enhanced magnetic resonance angiography, right? Gadolinium enhanced three-dimensional magnetic resonance angiography. That is the screening procedure of choice. And what is the confirmatory test? The confirmatory test is contrast enhanced arteriography, right? Contrast enhanced arteriography, right? Then how do you treat? See, if there is like unilateral renal artery stenosis, you can give the ACE inhibitors or the angiotensin receptor blockers. But when there is bilateral renal artery stenosis, the ACE inhibitors, they are absolutely contraindicated. They're absolutely contraindicated. And whenever there is bilateral renal artery stenosis, either you need to do surgical treatment, that is PTRA. That is, what is PTRA? That is percutaneous transluminal renal angioplasty has to be done when there is bilateral renal artery stenosis, right? And usually these patients with bilateral renal artery stenosis, they present with recurrent flash pulmonary edema and they will be requiring this PTRA, right? So that is about your renal vascular disorders, that is renal vein thrombosis and renal artery stenosis. Now we will move on to the next important, that is the nephrotic syndrome, right? So we'll discuss nephrotic and as well as nephritic. So what all we have finished until now? Acute renal failure, chronic renal failure, renal replacement therapy, renal tubular acidosis, then renal vascular disorders, right? The renal vein thrombosis and renal artery stenosis. We are done. Now let me discuss about the nephrotic syndrome. So in nephrotic syndrome, you will not only have renal, you also have extra renal manifestations as well. What are those renal and extra renal? See, the investigation of choice will be proteinuria. And how much will be the proteinuria? More than 3.5 grams per 24 hours. That is the investigation of choice. And the protein which is predominantly excreted is albumin. So that is the reason why these patients, they will also have hypoalbuminemia. And because of hypoalbuminemia, they present with edema. Apart from this, the other manifestations in nephrotic will be, there will be hyperlipidemia, there will be hypercoagulability, right? And you will also see the presence of the lipiduria. So what is this lipiduria? Lipiduria is the presence of the oval fat bodies within the urine, right? Presence of oval fat bodies within the urine. So these are the manifestations in patients with the nephrotic syndrome, and the predominant protein which is being lost is albumin. But let me tell you, in nephrotic syndrome, it is not only the albumin which is being lost. These are all the other proteins which are being lost. See, transferrin is being lost. So because of which the patient can present with iron deficiency anemia. Polycalciferol binding protein is being lost. So that is the reason why the patient can have hypocalcemia. Thyroxine binding globulin is being lost. So that is the reason why they can have thyroid abnormalities. Ceruloplasmin is being lost. So that is the reason why there will be impairment in the metabolism of your copper. Antithrombin 3 is being lost. That is the reason why there is increased the coagulation. Immunoglobulin is being lost. So these individuals, they are at increased risk of infections. So these are the other proteins which are being lost, but the predominant protein which is being lost is the albumin, right? Next, the next important thing is the coagulation factors. See, these patients with nephrotic syndrome, there is hypercoagulability. Why? Because there is increased synthetic capacity of the liver as a compensatory process of increasing the albumin synthesis. So there is increase in the synthesis of coagulation factors. Which all coagulation factors are increased? That is, increase in the factor 1, that is your fibrinogen, right? And next to this, there is increase in your factor, that is labile factor. Increase in the factor, that is stable factor. Increase in, right, increase in factor 8 and increase in factor 12 and increase in factor 13. So these are the coagulation factors which are increased in patients with the nephrotic syndrome. And not only that, the other cause for the hypercoagulability in nephrotic syndrome is, apart from increase in the coagulation factors, there is also decrease in the natural anticoagulants. What are natural anticoagulants? Protein C and protein S. This protein C and protein S is being lost. So once this particular protein C and protein is being lost, that is also the factor that will contribute to the development of the hypercoagulability. And you should know what are the causes of nephrotic syndrome. Most common cause of nephrotic syndrome in adults will be diabetes mellitus. Most common cause of nephrotic syndrome in children will be minimal change disease. And the most common, I'm sorry, one second. In adults, the most common cause of nephrotic syndrome will be focal segmental glomerulosclerosis. And what is the most common systemic disease that can cause nephrotic syndrome will be diabetes mellitus, right? And what is the most common cause of nephrotic syndrome in elderly individuals, right? That will be membranous glomerulonephritis. Okay, so these are all the etiologies that will be causing where you will have the nephrotic syndrome, right? Now let me take up the discussion of these individual forms of nephrotic syndrome as a quick recap. Now you see this question: a 7-year-old boy presented with the generalized edema. Urine examination revealed marked albuminuria, and serum biochemical examination showed the presence of the hypoalbuminemia with hyperlipidemia. The kidney biopsy was undertaken. On light microscopy, the kidney appeared normal. Electron microscopy, what exactly will be the finding? See, this entire picture in a 7-year-old boy, what is it suggestive of? This is suggestive of minimal change disease. Electron microscopy picture in minimal change disease, what is that you will observe? You will observe that there is fusion of food processes, right? Fusion of food processes. Okay. Now, let me take, and so in case of minimal change disease, light microscopy will be absolutely normal. Electron microscopy is the one which will show you the fusion of the food process. And what is the drug of choice in patients with minimal change disease? That is, you need to give prednisolone, right? Those individuals who have steroid resistant minimal change disease, in them you need to give cyclosporin or cyclophosphamide can be given, right? In steroid resistant nephrotic syndrome of minimal change disease, right? Next, so that was the nephrotic syndrome in children. Electron microscopy will show you the fusion of the food processes, right? Right. Then you take the diabetes mellitus. So diabetic nephropathy, that is the most common cause, most common systemic disease that can cause the nephrotic syndrome. In diabetic nephropathy, if you take a biopsy, you have the features like diffuse glomerulosclerosis and you have the features like nodular glomerulosclerosis. But which is more common between these two? Diffuse is more common than compared to that of nodular glomerulosclerosis. And what will be the earliest manifestation in diffuse glomerulosclerosis? The earliest manifestation in diffuse glomerulosclerosis is thickening of the glomerular basement membrane. That is the earliest manifestation. And you also have the exudative lesions, that is capsular drops and fibrin caps. Whereas in nodular glomerulosclerosis, the presence of nodular glomerulosclerosis, that will be pathognomic of your diabetic nephropathy. And what is the name of these lesions in case of nodular glomerulosclerosis? These particular lesions, they are called as the KW lesions, that is called Kimmel-Steele-Wilson's lesions, or these are also called intercapillary glomerulosclerosis, right? This is also called intercapillary glomerulosclerosis. So this is what is called nodular glomerulosclerosis, right? So these are the two forms in the biopsy, diffuse and nodular. Most common diffuse, pathognomic is nodular, and that is nothing but your Kimmel-Steele-Wilson lesion, right? And what is the drug of choice for diabetic nephropathy? That is, the ACE inhibitors should be given for diabetic nephropathy. And you take the minimal change disease. Just now we have discussed about the minimal change disease. What is that? Light microscopy, no abnormality. Electron microscopy, fusion of the food process. And immunofluorescent microscopy, you don't have the immunoglobulin or complement, right? Immunofluorescent microscopy, there is absence of immunoglobulin or complement. That is what is the picture in case of minimal change disease. Then focal segmental glomerulosclerosis. Focal segmental glomerulosclerosis, it is the most common form of nephrotic syndrome in adults. So if you take, you should know light microscopy, electron microscopy and fluorescent microscopy. You take light microscopy. Light microscopy, it will show you that it is not the entire glomerulus, it is the part of the glomerulus which is involved, right? It is the part of the glomerulus which is being involved, and it is only some segments of glomerulus which are being involved in light microscopy. Whereas electron microscopy, if you see, you will observe the presence of the hyaline deposits, fluorescent. And not only that, the electron microscopy, you will also notice the podocyte foot process effacement, right? There will be effacement of the podocyte foot process, and there will be also hyaline deposits. And fluorescent microscopy, that will be normal. That means there is no immunoglobulin in case of the fluorescent microscopy in focal segmental glomerulosclerosis. And this focal segmental glomerulosclerosis, this is also called as reflux nephropathy. This is also called reflux nephropathy. And this focal segmental glomerulosclerosis, it mainly occurs due to reflux of the urine from the bladder to the kidney. There will be hydronephrosis in focal segmental glomerulosclerosis, right? And this focal segmental glomerulosclerosis, one of the very important etiologies, HIV. Thus we call it as HIVAN, HIV associated nephropathy, right? Then you take the biopsy picture in membranous glomerulonephritis. Membranous glomerulonephritis, what did I tell you? Right, it is the most common form of nephrotic syndrome in elderly individuals. So if you take light microscopy, electron microscopy, and fluorescent microscopy. So in light microscopy, in membranous glomerulonephritis, you will have the characteristic spike and dome pattern, right? Spike and dome pattern. And this particular spike and dome pattern results from projections of the excessive glomerular basement membrane. Okay, so you will notice that there is spike and as well as dome pattern. And what is the stain we used? That is methenamine silver stain we use, right? The stain what we use to look for spike and dome pattern, methenamine silver stain. Now, when you do an electron microscopy, you will be able to make out what is the cause of this spike and dome pattern. So you will have the subepithelial deposits, and that is what is responsible for the spike and dome pattern. And the fluorescent microscopy, you will observe that there is IgG and as well as C3 in case of the membranous glomerulonephritis. Okay, so this is the biopsy picture in membranous glomerulonephritis. So, right, so to quickly recap, in diabetic nephropathy, you have diffuse glomerulosclerosis, most common, and nodular glomerulosclerosis, that will be pathognomic, that we call it as Kimmel-Wilson lesion. Minimal change disease, light microscopy, no abnormality. Electron microscopy, you will have the fusion of foot process. Focal segmental glomerulosclerosis, light microscopy will show you that only few glomeruli are being affected. In electron microscopy, you will have the presence of the hyaline deposits and effacement of the foot process. Membranous glomerulonephritis, light microscopy, you will have the spike and dome pattern. Electron microscopy, you will have subepithelial deposits. Fluorescent microscopy, you will have IgG and as well as the C3, right? And in diabetic nephropathy, ACE inhibitors are the drug of choice. Minimal change disease, you need to give steroids. And even in focal segmental glomerulosclerosis, we give steroids. And here, membranous glomerulonephritis, along with steroids, they also require the other drugs like cyclophosphamide or cyclosporin or your these are the other immunosuppressive drugs that can be given in case of membranous glomerulonephritis. Okay, so with this, we are done with the topic related to nephrotic syndrome. And these patients with minimal change disease, you have to remember one important point: they have good prognosis, right? Very good prognosis will be there in these patients with the minimal change disease, right? So with this, we are done with the nephrotic syndrome. And this is what is your focal segmental glomerulosclerosis. What did I tell you? It is called as reflux nephropathy. So you will observe that there is a hydronephrotic kidney, and in the light microscopy you will observe that it is only the part of the glomerulus which will undergo the sclerosis. And what are the etiologies that will be causing focal segmental glomerulosclerosis? It is mainly the infectious pathology like HIV. And other infections are HBV, human papillomavirus, hypertensive nephropathy, heroin addiction, sickle cell anemia, massive obesity. All these can cause the focal segmental glomerulosclerosis, right? So with this, we are done with the topic related to nephrotic syndrome. Now we'll move on to the discussion related to the nephritic syndrome. So if you take nephritic syndrome, the very important point in nephritic syndrome is the proteinuria. But how much will be the proteinuria? That will be 3 grams per 24 hours. And in these individuals, they will have hematuria. Usually in nephrotic syndrome, you don't have hematuria except for focal segmental glomerulosclerosis. But hematuria is very classical in case of the nephritic syndrome, right? And these patients, they will also have hypertension and they will also have the oliguria. right? And in all the forms of nephrotic syndrome, you don't have hypertension. In minimal change disease, the blood pressure will be normal, but in all the forms of nephritic syndrome, there can be hypertension. And what are the forms of your nephritic syndrome? See, the nephritic syndrome, right? You have IgA nephropathy, and as well as post-streptococcal glomerulonephritis, and as well as the Good-Pasteur syndrome, right? Let me discuss these three important conditions now. You take IgA nephropathy. See, these patients with IgA nephropathy, they present with the early hematuria, right? That means the hematuria will be there within 2 to 4 days of the infection. Within 2 to 4 days of infection. And this IgA nephropathy is also called as Buerger's disease, and the hematuria will be recurrent gross hematuria. Recurrent gross hematuria, right? And these patients, complement levels will be normal, right? ASO titer will not be elevated. ASO titer will not be elevated in these patients with the IgA nephropathy or Buerger's disease. But very important is, in IgA nephropathy, you need to know the biopsy. What will the light microscopy show in IgA nephropathy? You will observe that there is mesangial proliferation in IgA nephropathy. Whereas the fluorescent microscopy, you will see that there is presence of IgA and as well as C3 within the mesangium. And electron microscopy, right? Electron microscopy, you will observe that there is mesangial and as well as paramesangial deposits. Mesangial and paramesangial deposits. That is what is the story of your IgA nephropathy or Buerger's disease. What will be the biopsy picture, right? Then you take post-streptococcal, and in these patients with IgA nephropathy, let me tell you, serum IgA levels, there is no diagnostic value. It should be the renal IgA levels. That means the fluorescent microscopy IgA levels, that should be high, and that is what is the diagnostic picture in case of the IgA nephropathy. And how do you treat this IgA nephropathy? We give steroids. Along with steroids, we also give cyclophosphamide. So steroids and as well as the cyclophosphamide, they are very important in case of the IgA nephropathy. Then post-streptococcal glomerulonephritis. See, post-streptococcal glomerulonephritis, as the word itself tells you, it is secondary to group A beta hemolytic streptococcal throat infection and as well as skin infection. And light microscopy, what is that you will observe? Light microscopy, you will have that there is presence of diffuse proliferative glomerulonephritis, right? Diffuse proliferative glomerulonephritis, and you will observe that there is infiltration of the neutrophils, right? Infiltration of the neutrophils within the capillary lumen, right? And you will have the characteristic starry sky appearance. Characteristic starry sky appearance. Okay. And when you do an electron microscopy, you will see the presence of the humps. You will see the presence of humps. What are these humps? These are nothing but dome-shaped subepithelial deposits, right? Dome-shaped subepithelial deposits, right? And immunofluorescent microscopy, that will show you the presence of C3 and as well as the IgG. That is what is your post-streptococcal glomerulonephritis. Okay, right. Now coming to, in post-streptococcal glomerulonephritis, the treatment is completely symptomatic treatment, and we don't give any antibiotic because the infection was long back. It is not the present infection, so there is no role of antibiotic. If these patients develop hypertension, you need to give antihypertensives. So symptomatic treatment should be given in PSGN, and these patients, they have good prognosis. They will not have any recurrence. There is no recurrence in PSGN. But in case of IgA nephropathy, the recurrence is very high in IgA nephropathy, but there is no recurrence in PSGN. Coming to your Good-Pasteur syndrome. So if you take Good-Pasteur syndrome, it is an autoimmune disease, right? Where the antibodies, are being formed against alpha 3 chain of type 4 collagen, right? The antibodies are formed against alpha 3 chain of the type 4 collagen of the basement membrane within the kidney, of the basement membrane of the alveoli, right? Of the basement membrane of the kidney and alveoli. So when the antibodies are formed against the basement membrane of the kidney, these patients, they develop rapidly progressive glomerulonephritis and they can have hematuria. And when the antibodies are formed against the basement membrane of the alveoli, these patients, they can develop intraalveolar hemorrhage, and that too, it is focal necrosis of the alveoli. It is not the diffuse necrosis of alveoli. Please remember, this is an important MCQ, right? It is a focal necrosis of alveoli causing intraalveolar hemorrhage, causing hemoptysis, right? Causing hemoptysis. So hematuria and hemoptysis is a classical presentation in patients with the Good-Pasteur syndrome. So even though it's an autoimmune disorder, it is more common in males than compared to females. The ratio is almost like 6:1. And what is the investigation of choice here? the investigation of choice is anti-glomerular basement membrane antibodies. The sensitivity of this test is almost 90%, right? And what you will see in the biopsy, actually, the renal biopsy is the gold standard investigation. Renal biopsy is the gold standard investigation. So in the renal biopsy, you will observe that there is diffuse proliferative glomerulonephritis. And when you do an immunofluorescence, immunofluorescence will reveal the linear deposits. Okay, so that is what is your Wood-Passett syndrome. And how do you treat these patients with Wood-Passett syndrome? You need to do plasmapheresis. Whenever you do plasmapheresis, that will take out the antibodies. So that is about your Wood-Passett syndrome. So Wood-Passett syndrome, it is the one which will cause nephritic syndrome. It's an autoimmune disorder. The antibodies are being formed against alpha-3 chain of type 4 collagen of alveolar and as well as glomerular basement membrane, causing hematuria and as well as the hemoptysis. Serology, anti-glomerular basement membrane antibodies are present in almost 90% of patients, and the investigation of choice is renal biopsy, which will show you diffuse proliferative glomerulonephritis, and immunofluorescence will reveal the linear deposition. And the treatment is plasmapheresis that will take out the existing antibodies. After doing plasmapheresis, you need to give a combination of, right, you need to give a combination of plasma exchange and as well as the corticosteroids. So these corticosteroids can be combined with azathioprine. So these corticosteroids and azathioprine, that will prevent the new antibody formation. Okay, so that is about your Wood-Passett syndrome, which will be your nephritic syndrome. Okay, right. Now, after having discussed about the nephritic, we will move on to the hereditary disorders of the kidney. So what are the hereditary disorders of the kidney? Like you have Barter's, Gitelman's, Alport's, and even Liddle's. So in Barter syndrome, what exactly is seen? In Barter syndrome, what is the problem? Metabolic acidosis, then hypokalemia, hyperkalemia, decrease in the urinary calcium. So first of all, let me tell you what exactly is your Barter's, and then we'll come back to this question. See, Barter's, it is the one where the pathology resembles the loop diabetic. See, Bartter syndrome, like we have type 1 to type 5. So, type 1 to type 4 is autosomal recessive type of inheritance. Type 5, it is autosomal dominant type of inheritance. And this Barter's, it resembles what? Loop diabetics. That means what? That means in Barter's, there will be defect in sodium potassium 2 chloride channel. Where is this sodium potassium 2 chloride channel? That will be present in ascending limb of loop of Henle. And even your loop diuretics will also inhibit the sodium potassium 2 chloride channel. So remember, in Barter's, it resembles the loop diuretics because the pathology will be in the sodium potassium 2 chloride channels. Now in these patients, what all will be the abnormalities? Let me discuss. See, in these patients, I said we have 5 types of Barter's. So out of which your type 1 to type 4, it is autosomal recessive, and type 5, it is the autosomal dominant type of inheritance, right? Now, what will be the clinical presentation in these patients with the Barter's? See, this is what the appearance of the individual with the Barter's. So they will have this characteristic triangular facies. The eyes will be very large eyes, and you take the ear pinna, they'll have large ear pinna, and they will also have the renal failure. And these patients, they also have sensory neural hearing loss, like your Alport syndrome. Patients early in the life, they can also have sensory neural hearing loss. And the classical clinical presentation in these patients with the Barter's is they will have polyuria, they will have polydipsia, along with that, they will have hypokalemic metabolic alkalosis. Right, hypokalemic metabolic alkalosis, and the blood pressure will be normal. That means without hypertension. So hypokalemic metabolic alkalosis without hypertension, that is what is the classical presentation in case of the Bartter syndrome. So if you go back to this question, right, if you go back to the question, right, metabolic acidosis will be there and hypokalemia will be there, but hyperkalemia will not be there, and there will be decrease in the urinary calcium concentration. So one second. The question asked is what? Which of the following is being seen? So in these individuals, like what is being seen? It is your hypokalemic metabolic alkalosis. I'm very sorry. It is hypokalemic metabolic alkalosis. Okay, not metabolic acidosis. Hyperkalemia will not be there. And what will happen to your urinary calcium? There will be increase in the urinary calcium levels. I'm very sorry for that. So the answer will be hypokalemic metabolic alkalosis. So that is what is your Bartter syndrome, right? And in Bartter syndrome, even your renal prostaglandin E2 levels, they are elevated, right? So your urinary calcium levels, either they are normal or being elevated. That is what you will see about the urinary calcium in case of the Bartter syndrome. What is the age of presentation of the Bartters? That is usually early in the life. Predominantly, it is autosomal recessive. Only type 5 Bartters, it is autosomal dominant type of inheritance, right? Then, followed by that, we'll move on to the discussion of the Gentleman syndrome. Okay. So, if you take this Gentleman syndrome, this will resemble the thiazide diuretics. Right, this will resemble the thiazide diuretics, and here also it is autosomal recessive type of, right, here also it is autosomal recessive type of inheritance. And what is the problem in Gentleman's? When we are telling that it is resembling thiazide diuretic will act at the level of distal convoluted tubule. It will block the sodium chloride symporter. That is what the thiazides do. And in Gentleman's, the problem is this particular channel, that is sodium chloride symporter or co-transport, does not work. There is a defect in this particular channel. And the age of presentation will be late childhood. The age of presentation will be late childhood. And these patients, the blood pressure in these individuals will be absolutely normal. And even these patients also, they will have polyuria. Even these patients also, they'll have polyuria. And in these patients, how do you diagnose? If you take, they will have chloride resistant metabolic alkalosis. And these patients also, they will have hypokalemia similar to that of your Bartters. And these patients, if you take the magnesium levels will be reduced. That is one of the very important difference between Gentleman's and Bartters. In Bartters, the magnesium levels will be normal serum magnesium in Bartters. But whereas, right, normal magnesium level in Bartters. Whereas in Gentleman's, the magnesium levels will be reduced. That's one of the important point of difference. Now, why is that the magnesium levels are being reduced? Because there will be also defect in TRPM6 in Gentleman syndrome. TRPM6 is the one which will reabsorb the magnesium. So there will be decreased serum magnesium levels, right? And what will happen to your urinary calcium excretion? There will be also decreased urinary calcium. But what was the calcium in Bartters? The urinary calcium was normal. The urinary calcium was normal, or occasionally it may be increased, but here the urinary calcium levels will be reduced. So that is another important point of difference between Gentleman's and as well as Bartters. But both of them, please remember, they will have hypokalemia. Both of them, please remember, they will have normal blood pressure. They will have normal blood pressure, right? So this is about your Bartters and Gentleman's. Bartters resembling loop diuretics, Gentleman's that will resemble the thiazide. Okay, right. Now, once we are done with these two, the next important is the Alport syndrome. The next important is the Alport syndrome. So now what will be the, okay, one more. Yes, you see this. Hypertension with hypokalemia. Where do you come across this? You come across this in Liddle syndrome, right? Now, what is this Liddle's? Liddle's is increase in the ENaC activity, right? Increase in the epithelial sodium channel activity. And once there is increase in epithelial sodium channel activity, there will be sodium and water retention causing hypertension, and there will be potassium excretion causing hypokalemia. There will be H+ion excretion causing metabolic alkalosis. And remember, in Liddle's, what is the drug of choice? See, you want to block this ENaC, so you need to give epithelial sodium channel blocker. What is that particular epithelial sodium channel blocker? Like we have amiloride, then triamterene. Right, amiloride and as well as triamterene. So this is about your Liddle syndrome. Okay. So in all these, whatever we have discussed until now, you take Bartters, you take Gentleman's, you take Liddle's. In all of these, you have the metabolic alkalosis and you have the hypokalemia, right? You have the hypokalemia, right? Whereas in Bartters and Gentleman's, hypertension is not there, but in Liddle's, you have the hypertension. Okay, right. Now, next is about the, yes, you see this question. So, mutation in alpha 5 chain of type 4 collagen. See, if the mutation is there in alpha 3 chain of type 4 collagen, good pastures. But if the mutation is there in alpha 5 chain of type 4 collagen, that becomes your Alport syndrome. So, Alport syndrome, it is characterized by a classical triad. What is that classical triad? Number one, there will be hereditary nephritis, because of which they can have the hypertension. They can have the hypertension. Next, these patients, they will have sensory neural hearing loss. Why? Because your alpha 5 chain of type 4 collagen is also present within the cochlea. It is also present within the cochlea. So that is the reason why there is sensory neural hearing loss. And this alpha 5 chain of type 4 collagen is also present within the cornea or within the eye. So the ocular abnormalities will be in the form of anterior lenticonus, right? Ocular abnormality will be in the form of anterior lenticonus. And these cornea ulceration will be there. There will be recurrent corneal erosions, and not only that, these patients will also have the cataract. So this is a triad in Alport syndrome. So hereditary nephritis, and because of hereditary nephritis, they can also have the hematuria. They can also have the hematuria. So hematuria, that is the earliest manifestation in patients with the Alport syndrome. Earliest manifestation, right? And what is the most common extrarenal abnormality? Most common extrarenal abnormality will be the sensory neural hearing loss. And most common ocular abnormality will be the anterior lenticle. Okay, so this is about your hereditary disorders of the kidney. So Barter's, please remember, it will resemble the loop diuretics. Gentleman's, please remember, it will resemble the thiazide diuretics. Liddle syndrome, that is due to increase in the ENaC activity. Alport syndrome, that is due to defect in alpha 5 chain of type 4 collagen, because of which you have a classical triad, that is hereditary nephritis, sensory neural hearing loss, and then ocular abnormalities. So with this, we are done with the entire nephrology revision. Right? With this, we are done with the quick revision of the entire nephrology.